So, Madam Chairwoman, dear colleagues, first and foremost, I would like to thank the organizing committee and its president for the opportunity to present here in this Congress. Let me start in the next few minutes to explore the link between iron deficiency, heart failure, and cardiorenal syndrome. We know for a long time that cardiorenal syndrome refers to the complex interplay between cardiac and renal function. It covers a range of disorders, renal and cardiac disorders, wherein the diminished function of one organ can result in the compromised function of the other organ. We need to bear in mind, as far as iron distribution goes, that only a small amount of iron is actually absorbed through the GI tract, only 1 to 2 milligrams per day. Liver and reticuloendothelial cells are the main stores for iron, while only 3 milligrams is the actual amount of iron that is bound to transferrin. I was saying about the iron distribution. I don't know where I was cut off. Only a small amount of iron is actually bound to the to transferrin in order for it to circulate through our vessels. We need to not forget the iron-containing enzymes that use around 100 milligrams of iron in order for the proper usage. And going on to erythropoiesis, as I've already mentioned, 3 milligrams that is bound to transferrin is not enough for erythropoiesis. Erythropoiesis, the bone marrow needs 20-25 milligrams per day for proper erythropoiesis. That means that the iron is actually turned over 6 to 7 times per 24 hours. Iron plays a crucial role for the proper function for specific proteins that, as you can see in this table, are mainly in cells that require quite a lot of energy, such as hepatocytes, renal cells, cardiomyocytes, or cells that have a high mitogenic activity. That can mean that the iron deficiency might have issues with this kind of organs and this kind of cells. We understand that the interaction between CKD, anemia, and iron deficiency it's long being recognized. HF and chronic kidney disease are independently associated with inflammation and overactivity of sympathetic nervous system that can cause impaired iron homeostasis. On top of that, as CKD continues, we see that there is some kind of deficiency in erythropoietin, and fluid overload and hypovolemia is a common entity between heart failure and chronic kidney disease that can lead to anemia. What are the causes of iron deficiency in heart failure? Reduced iron intake, reduced iron absorption, increased iron loss, and the functional iron deficiency that we see in the myocardium, where due to neurohormonal activation, there is issues with iron utility in the myocardial In CKD, we see that there is a reduced activity of transferrin, and the amount that can be bound is only reduced to 2 milligrams. That means that there are issues with erythropoiesis as well. On top of that, in addition, we see that inflammation that can cause metabolism abnormalities and hepsin, the induced intestinal iron absorption failure or binding of iron in macrophages and hepatocytes. So it can be argued that maintaining iron homeostasis is not crucial only to erythropoiesis. It can affect organs with intensive metabolism or high energy requirements, such as kidney, muscles, liver, etc. Going on to numbers, the incidence of iron deficiency is not specific. There is considerable variation throughout the studies. In this one that involves more than 12,000 patients from Canada with newly diagnosed heart failure, 70% of those had anemia, while 21% of the anemic patients had iron deficiency. In this retrospective study of 5 centers in 3 countries, we see that there is an incidence of 26% of patients who were diagnosed with cardiorenal syndrome. In those cardiorenal syndromes, 56% had iron deficiency versus 50% of all patients. In the 2.5 years of follow-up, it was revealed after multivariate analysis that iron deficiency alone was associated with higher risk of mortality, with a hazard ratio of 1.42 as seen in the table. And that was irrespective of anemia and CKD. In another study that involved more than 2,100 patients with heart failure, cardiorenal syndrome was apparent in more than 55% of those patients. Iron deficiency was present in 69% of the cardiorenal syndrome patients versus 50% of the patients with normal kidney function. In this study as well, isolated iron deficiency was found to have a correlation with mortality with an adjusted HR of 1.53. Okay, we see iron is important in patients with heart failure and cardiorenal syndrome. What kind of iron? We've learned from many studies throughout the years that in CKD population, intravenous iron has a superiority as far as comparing to oral iron supplementation. What about in HF populations? In this study involving 105 patients who received oral iron supplementation, the authors found that oral iron increased transferrin saturation, ferritin levels, and hemoglobin. Based on those findings, the iron out study was designed. In this, the results of those studies was not promising. As you see in the highlighted area, only 3% increase in transferrin saturation. It didn't have any significant improvement in ferritin levels. And notably, it did not demonstrate any effect on exercise capacity. Ferric HF study was the first of many that tried to compare IV iron supplementation versus placebo. You see the protocol of iron sucrose that it was used in this 35 patient study with a follow-up period of 18 weeks. The results of those study, apart from increasing transferrin saturation and ferritin levels, was that IV iron administration improved fatigue score, patient global assessment, and NIHA functional class. On the FAIR-HF study, where 456 patients were randomized, as you see on the left, 50% of the patients who were on the IV iron arm reported self-reported match or moderately improvement versus 27% in the placebo group. On the right hand, you see the difference between the NIHA functional class at week 24. 47% of patients on the IV iron group had NIHA functional class 1 and 2 versus 30% on the placebo group. results that were in the cardiorenal syndrome patients, you see over there the highlighted area. The results were the same in favor of the ferric carboxymaltose group. The study didn't show any issues regarding safety. The only difference was for cardiac disorders, investigator-reported adverse event, which was in favor of the IV iron group. CONFIRM-HF study came to confirm all those results. You see the treatment protocol that it was used, and similar findings in regards to self-reported global assessment and NIHA functional class improvement. These improvements were apparent from week 24 onwards. This was the first study, the CONFIRM-HF study, that showed some significant difference when it comes to events on hospitalization due to HF, as you see on this table. 2022 came, and the results of the AFFIRM AHF trial were published. What you see here is that even though there were fewer events when it comes to the composite primary endpoint of heart failures, hospitalization, and cardiovascular death, it didn't reach statistical significance. And the results were the same in regards to staging of CKD as well. But due to the fact that this study was performed during COVID-19 happened, and when the authors did a COVID-19 sensitivity analysis, meaning that they actually excluded any results from when COVID-19 happened, all primary endpoints when it comes to total heart failure hospitalization and cardiovascular death, total cardiovascular hospitalization and cardiovascular death, and total heart failure hospitalization did reach statistical significance, as seen in the table. Last year, the Ironman study came. It had similar findings, similar problems, reaching statistical significance due to COVID, and did reach statistical significance in the primary endpoint when COVID-19 sensitivity analysis happened. But what I would like you to see from this study is some results that are in the supplementary material, and it involves patients with low eGFR, meaning that patients who had an eGFR of below 60 had a 23% reduction of primary endpoint, and patients with an eGFR below 42.3 had a 29% reduction of the primary composite endpoint. Recent meta-analysis of 7 trials confirmed these findings, that IV iron supplementation reduces the risk of composite outcome of first heart failure hospitalization and cardiovascular mortality, but mainly due to the fact that it actually reduces heart failure hospitalization. Another meta-analysis of 10 randomized controlled trials involving more than 3,400 patients had similar effects as far as composite outcome and hospitalization for heart failure. I would like you to see a few data that involves cardiorenal syndrome patients and kidney function and IV iron supplementation. Results from an analysis that was done in the FAIR-HF study, and when comparing the 203 patients with an eGFR below 60 to patients who had an eGFR above 60, it was shown that IV ferric carboxymaltose administration was associated with improved renal function after 24 weeks, as seen in the figure. Similar findings were apparent in another study that was actually designed for a completely different thing. They want to review changes of echo parameters in cardiorenal syndrome patients while giving them IV iron. But what the results have shown were that patients who were on the IV iron sucrose group, after 6 months of treatment, had a significant improvement of renal function in the intervention group, while creatinine clearance was reduced in the control group. In the coming years, we're eagerly awaiting for these two studies. Hopefully, they will shed more light in this topic. Before closing, I would like you to see the guidelines and the difference that there is in these guidelines when it comes to targets that our cardiology colleagues and our we nephrologists are aiming for ferritin levels and transferrin saturation. Without actually having a lot of data to support that, I think that we need to say to our cardiology colleagues that they might be needing to aim a little bit higher. In summary, intravenous iron administration plays a significant role in management on patients who have cardiorenal syndrome and iron deficiency. Unfortunately, there are not a lot of data when it comes to that. More studies are needed, but what do we know right now is that IV iron is improving symptoms, is improving functional capacity, and is reducing hospitalization. Moreover, there might be some potentially positive effect on kidney function. Overall, intravenous iron emerges as a valuable therapeutic option on these patients. Hopefully, with future research, we'll have more to say about this topic. Thank you very much for your attention.